in.
Yes.
Good to go.
Yes. Get it. See this now? Microphone is reading us. Looks good to go on YouTube. Oh, there isn't at all. Okay. Turn it over to you all. I'll be joining on my computer just over there. So if you need anything, I'll be listening in. Is that good? Thank you. All right. I'll have you guys give me like a test 1, 2, 3.
Test 1, 2, 1, 2. Test 1, 2, 3. Can you hear us?
We can hear you.
Wonderful.
Thank you, Heather.
I don't know if my headphones are just too far away.
Good morning, everyone. Welcome to the Northern Kentucky Area Development District Regional Aging Area Plan public hearing. It is February 22nd, 2022, 2/2/22, and 2/22/22. We were actually going to have this meeting at 2 p.m. to make it all twos, but that didn't quite work out for us today because of a conflict with the Zoom schedule. I would like to let you know that we are having this meeting is being live streamed. That is required during any public hearing if we're doing it virtual. So we are doing it live stream on our YouTube channel right now. I would like to quickly let you know who's in the room here with us, and then I'm going to go through the list of who is on the who is with us virtually, and that is for the benefit of our scribe today. So I'm Ann Wildman. I'm the Associate Director of Aging and Disability Services here at the Area Development District. To my left is Shannon Kelch, Senior Human Services Specialist, Senior Aging and Disability Specialist. And then Stacy Phillips is with us. She is our in-home services supervisor. She is serving as our scribe today. And Quinn Calbaugh, and Quinn is our student intern from Northern Kentucky University. That's who's in the room with us today. Shannon, can you pull up? And with us online is Alicia Campbell, Alan Reinecke, Amanda Hartkorn, Becky Darnell, Bethany Freckle, Connie Baker, Diana Tripp, Dylan McCormick. I have somebody that is under fire tablet. Can you identify yourself, please?
That would be me, Pat Conrad.
Pat Conrad. Thank you, Pat. All right. And Heather Hopton, Janet Frakes, Joseph Smith from Mom's Meals, Katie Fawcett, I'm guessing that's Katie, that's Katie Fawcett, Kelly Bond, Laura Kleiman, Laura Harold, Marcia Dufek, Michelle Thompson, Rosemary, Dr. Suki Kim, and Michelle Bonar. All right, I think we have everybody. That's a total of, do you have all those people, Stacy? Okay. So that's a total of 23 participants. That's pretty good that's pretty good. So what we're going to do today is I'm going to give a brief introduction of a background of what the area plan is, and then Shannon and I are going to go back and forth. We're going to go through the plan for you today, and we're going to go back and forth because it takes a little while to get through the plan. And talking a lot, it's you know, we want to share that job. So just by way of introduction, normally it would be every 3 years we would present for everyone's consideration a new area plan. A little different. COVID impacts everything, and it did with the area plan. So normally we would have done this last year because our area plan went through technically FY19 through FY21. But they extended the plan an additional year due to COVID. So we had that gracious extension for a year, and now we are on to a new plan. So just to give you a little bit of background, we are required to do this. This is a requirement that is passed down by the state. It is in federal legislation. So the state is required to submit a state plan, and then they submit that to the feds, to the Administration for Community Living, and then we are required as area agencies on aging to submit the plan to the State Unit on Aging, which is the Department for Aging and Independent Living. So that goes through a process. We go through a lengthy process. I will say, in case there are any questions about this, the plan is it's very much in a template form, and the template is designed by the state. So there's not really a lot of free scripting here, so to speak. I mean, the narrative is our scripting, but there's not a lot of room to just do our own, do our own writing and write our plan. It's very much fill in the box. This is what you need to do. This is what you need to write about. But we're going to go over our goals, and that's a big part of the plan. And there is a lot of freedom with that. I mean, the goals are, as far as our objectives and our strategies. So we do have to do a lot of planning around that. So we go through, we create our plan. Actually, I will say before we create our plan, we do a community needs assessment. That's very important in developing our plan, which I know all of you were probably a part of. We get the results of the community needs assessment, which helps us develop our plan. We spend a lot of time developing that plan, and then we're doing this public hearing today to get any input that you all may have, and we value that input greatly. Once we get that input, we will take that plan on to the Council on Aging. And for those of you who are sitting in today who serve on the Council on Aging, thank you very much. You'll be hearing some of this times two, and but we appreciate you attending the public hearing today so you can understand a little bit about the process. That's really, really important to us. So we will go through that, and then we will, once the Council on Aging reviews the plan and then approves it, we will go on to the NKADG Board of Directors to review the plan with them and seek approval. So that's a little bit about the process. Are there any questions before we get into the plan? Okay, if not, we'll go ahead and get started. So we're going to go ahead, if anybody, I know that we did publish the plan. The plan was available on our website. So we're going to start and talk a little bit about our mission and our vision, which it is very important. That's why we serve people, why we exist, and that is that we, as a development district, work to implement quality services through our areas of expertise in aging and disability, public administration, community development, and workforce development. So those are the 4 parts of the area development district. So we collaborate with local leaders and community partners by offering quality services that educate, empower, and enable people who live in our region. As a designated area agency on aging, so this is where we come into play, we provide, and this is our mission, resource solutions and services focused on improving the quality of life for older adults, caregivers, and those with disabilities. So that is our new mission statement as the area agency on aging. So that is important to us, very, very important. We were required to provide a narrative about the agency and the area it serves. So for those of you, I'm sure most of you know, our office is centrally located in Florence, and we serve residents of the 8 northern counties identified in the service portion of this plan, and that's very clearly outlined in the plan. Within the plan, we have a very strong and vital aging and disability resource center, and our ADRC provides long-term planning options and general information and referral regarding aging and disability services. The Area Agency on Aging also administers programs and services through state and federal resources, including home care, the personal care attendant program, Medicaid waiver, SHIP, the long-term care ombudsman program, Title III, and Title VII. In addition, we receive local fiscal court funding for case management services for older adults, which allows us to serve a larger population for vulnerable older adults. We also receive private foundation funding, which has enhanced our home delivered meal programs. That's been close to 10 years now, I think, that we've been receiving that funding, as well as partnerships within our community that provide additional support beyond what our federal and state dollars allow. And we're really, really thankful for that. So this year, the state has decided to they have changed their plan a little bit, the state plan, and this is something that's new in our plan. I did want to mention, a lot of the plan is, there hasn't been a tremendous amount of change to the structure of the plan, but what I'm going to talk to you about right now is something new in the plan. And the state was actually recognized for their mission statement and what I'm about to present to you. So this is, they wanted us to provide examples of how our agency is working to meet the Cabinet for Health and Family Services mission to be a diverse and inclusive organization, providing services and supports that protect, promote the health and well-being of all Kentuckians, providing examples of 4 different, what they call their 4 pillars: equity, health and well-being, resilient individuals and communities, and structural and economic support. So I'm just going to summarize that really quickly, what that means to us. In regard to equity, we strive for equity by providing equitable access to all services for all those that meet our eligibility criteria. As a part of this process, we'll be looking at increasing equity awareness to both staff and the general public through various social media outlets and incorporating that into our website. And we're going to also look at equity training for our staff that may enhance their knowledge base and incorporate equity practices into everyday work. So we're going to take a little closer look at equity and what that means. So really important part of our practice, integrating that into our practice. Health and well-being. So recently, the Area Agency on Aging joined the Health Collaborative. And for those of you who are not familiar, the Health Collaborative is a huge organization in Greater Cincinnati. It's a data-driven information. They bring together healthcare stakeholders in the entire region for the good of the community and provide us with data needed for healthier people, better care, and lower costs. And it really has been an amazing experience being a part of the Health Collaborative and getting some really great real-time data. We've been involved in one of their subcommittees that they have regarding long-term care, and it's been interesting just participating in those meetings and getting the data and understanding what's going on in our region's hospitals and long-term care settings and such. Really, really great information. That's part of it. And then we are also part of Northern Kentucky University's Age Friendly University Coalition. And this coalition is aimed at assisting the university to expand its impact and support older adults wanting to pursue higher education opportunities. So this is something that Shannon has been involved in, and so we will continue our involvement in that. And then the third area has to do with resiliency. So our elders and caregivers and those with disabilities are some of the most resilient individuals in our community. They have, as you know, they have a lot of obstacles, and each one has had to go through a lot to improve their quality of life. We look at that, and that is something that is really, really important. So having partnerships to things such as public health information and education through our local health departments, promoting social connectedness, sorry, can't get my words out this morning, connectedness through both virtual and in-person programming at our senior centers, partnerships with like Meals on Wheels of Southwest Ohio, Northern Kentucky, having a local commodity distribution warehouse to assist individuals to become resilient in the face of adversity. We're looking to expand our wellness activities, promote healthy lifestyles, and increase social cohesiveness through shared life experiences. So all these things we're doing to help bolster resiliency. As you know, our older adults, they are already pretty resilient, but we want to help with that, help them be even more resilient. So the fourth area, the fourth pillar is structural economic support. While this is not a primary function of the Area Agency on Aging, it is an area in which we can make direct impact on. Our workforce has taken a hit, and I think everybody knows this. And historically, the workforce has struggled to find value in the older adult and the disabled worker. So they now find themselves short-staffed, which is a great opportunity to increase knowledge on the importance of equity, well-being, and resiliency. And this lends itself to opportunities to partner with our workforce department and community partners in the disability field. And this will help us to provide innovative ways in which we can provide structural economic support in our region. So that's a little bit about the four pillars. We intend to really embrace those and move forward. Page 5 here, which we're showing, this is just a map of our service area. And as you can see, it's outlined, and you can see it here in color with all the cities, and that is it. Shannon's going to go through our profile, our revenue, and our services.
So let me preface this by saying a lot of the information that you are looking at right now is actually old information. COVID did a number on a lot of different sectors, including the data sector. So unfortunately, at this time, all the numbers that you see are reflective from the most recently published data that's out there. We have been informed by the Department for Aging and Independent Living via their sources that some of the data should be up by about mid-March. Unfortunately, that is after this is going to be voted on and published. What we will be doing, though, is updating the data and updating these pages. And so at that point, we will republish this particular page. So right now, I can go through it, but it's about 2 years old worth of data. So just kind of put a pin in that, and we'll get back to that when we get updated data. So there are a bunch of different funding sources that we have. The state wants us to reflect what is the percentage and the breakdown in all of our federal, state, and local funding. So as you can see here, about 12.85% of our funding are federal funds. The bulk of that is state funds. A very small percentage of fee-for-services. These are funds that are collected based on income, and again, it's just very, very, very small. There are match requirements that our providers have to meet in order to receive the federal and state funds, and the cash and the in-kind amounts at 2.12% and 1.61% are reflective of that. As we continue to break downhill, you're going to notice that the bulk of this 83% lies within our waiver program, as it is the largest program that we have. Please do keep in mind when I talk about these numbers for the waiver program, the most significant portion of that is actually a pass-through to the individuals receiving reimbursement for their services. The state asked us to include in the current fiscal year budget. And so this is what that is a breakdown of. Our OAA funding is our federal funding is just a little over 1.3 million. Our NSIP is our nutrition. I can never remember this.
Services, incentive program.
There we go. Basically, these are funds that go to help pay for raw food costs to expand our meal program. Again, we've got 2.2 million here that is state funded. This includes our home care and personal care attendant program. We do receive Centers for Medicaid Services funding. This is primarily our MIPA program, which is our health insurance program. Then we received approximately 1.7 million between all four of these, or all three of these funding sources. The CARES, COVID, and CRISA funding were the COVID response funds. And so we did receive a good chunk of that. We also received Medicaid ADRC funding that comes in from both match that the state that the ads have to use, and also does include some additional COVID response funding as it relates to Medicaid ADRC. 63,000 comes from state restricted funds for specifically for our ombudsman program. We also operate a pass-through account for the state that just totals 15,000. Literally, as requests come in, we just simply reimburse those funds as a way to make it actually a little easier for the state. We do receive the 211,000 our local funds, our cash funds that come again through the match providers. When we talked about the 0.5% that are the fees, this is roughly around $9,100. And then we also do in-kind contributions. The bulk of this is coming directly from our senior centers who donate the space in all of our centers. And then the largest is our consumer directed options. Again, this is budgeted at 9.9 million. So again, when you saw the 83%, that's a direct result of this 9.9 million. So overall operating budget is just a little bit over $16 million. And we do our due diligence to make sure that we are monitoring for those and using those funds in the most equitable and effective way. Services that we offer, there are a number of them that you're going to see listed here, and I'm not going to spend a tremendous amount of time going through all of them. Please take a little bit of time to kind of flip through them. I'm going to kind of just leave them here. All of the numbers that you are seeing on your screen right now are reflective of fiscal year 21. So that was July 1st of 2020 through June 30th, 2021. You will see these columns. So if it is a service that we provide, you're going to see yes. Do we directly provide it as the area you can see? Yes or no. And then do we serve that under contract? Yes or no. The number of people that were served last year, the amount spent, again, these are rounded, and these are the funding sources that are applied. Again, if there are very specific questions, please put those in the comments and we will get to those. There's a lot of other information that we really want to get through. So I'm just going to kind of just quietly scroll through this. And again, if you do have questions, please include those in the chat and we will get to those. So Ann had mentioned before that there were a number of new aspects to the plan. These next three sets of questions are also new to the plan. Fortunately for us, we have a shared statewide database, so access to this information is, unlike the other data, very relevant because it's coming directly from the individuals that we serve. So for our individuals who utilize Older Americans Act funding, this involves individuals who are at our senior centers primarily. We're serving 6.8% minority, 30.7% are low income. Our limited English proficiency is just sitting at just about 1%, and almost 30% is rural. Our home care funded, this is primarily our individuals who are,
Stop being illegal.
okay.
Came in and check out the microphone. Sorry to interrupt. You need controls.
Can you all hear us?
Yes.
Yeah, I can hear you.
Okay,
Good to go.
great. We thought we were having some technical
Sorry.
difficulties. Sorry about that. Thank you for your patience on this. Our home care funding is primarily our in-home services funding. These are individuals who are pretty much limited to in-home services. This is a much smaller group versus the group that we showed above. 7% of them are minority, about 54.8% are low income, 1% are, again, limited English proficiency, and 45.6% are rural. And for our waiver program, again, 15% minority, 30% low income. We are seeing a slightly higher group here with limited English proficiency, and 22% of them are rural.
Okay. So our next section is on partnerships and collaborations. And as you can see by the list, and I'm not going to go through every single one because a lot of these partnerships we've had for many, many years, as you can see. So I'm going to have Shannon scroll slowly through them. As you can see, the organizations like St. Elizabeth Crime-Wise, the Alzheimer's Association, the Burning Foundation, which I mentioned previously, the Butler Foundation, Bluegrass Care Navigators. You can see all of these. These are all organizations that we collaborate with. I will mention a couple of the newer ones. And they are the last two on the list. And that is the Health Collaborative. That is one that I mentioned. And I mentioned when I was talking about the pillars, this group we joined actually in 2020, and as I mentioned, their mission is that they are a group of powerful partners brought together to realize the vision of health-minded people of all ages, committed to making health and healthcare a value that we share. It's a professional organization, and it links us to the health community through data networking and professional relationships. And these are health, as I mentioned, these are hospitals and all types of healthcare organizations. And then we have Burn Along, and Burn Along is an online fitness and wellness platform, and we are in the process of utilizing their Tai Chi platform for our senior centers. So that is a newer partnership that we have established, and we haven't officially gotten the platform set up, but we are working on it. Okay, going to talk a little bit about our needs assessment, which is our capacity assessment, and we collect. This is when we collect information from seniors, caregivers, service providers, elected officials, committee members, and other interested citizens about our needs or gaps in services for older adults in our service areas. And we do that. And we collect this information by surveying clients, community partners, and interested parties. And we do that survey. It's available online or on paper. I'm sure many of you that are on the call today filled out that survey or had access to that survey. And if you filled out a paper survey, we entered that data online. We were able to analyze that data and determine our needs in our community and the gaps in service. And we will be publishing the results of that needs assessment fairly soon. So we typically do that needs assessment once every 3 years prior to the new area plan. And we conducted the most recent needs assessment in December of 2022. And the next one is scheduled for December of 2025. So then we're going to talk about our capacity building plan and we're going to talk about how we identified our top 3 overall agency goals for this planning cycle. So goal 1 will be accomplished as the ad overhauls our agency website. This goal will be accomplished as we look to make the area agency on aging and the services and resources we offer and provide stand out prominently on the website. We've been working on this for a while, and we're really committed to do this. We are also looking into design a new division logo and a tagline that we can use on our marketing material. We've already begun to look at new partnerships through the Health Collaborative, as well as the NKU Age Friendly University Coalition and our regional drug control policy team, which is housed here at the Area Development District. In the upcoming years, we will look to create new partnerships in the field of technology, as well as further establishing our relationship with first responders. This progress will be accomplished as we further look to expand Project Life Connect. And for those of you who are not familiar with Project Life Connect, this is a project that Stacy and Heather have been working on for a while now. It is the Red Envelope Project, where we provide these plastic envelopes to individuals where they can put their vital information, and they're magnetized, so they can put that on their refrigerators, and first responders can have easy access to that information. So they're looking at getting that information into those cities who have a social worker who assists first responders, and then into those cities where a social worker is not available. So several of our cities have police social workers now, and so we're looking at targeting those first. This will be a 2-year goal, and we hope to accomplish that with the help of a student intern as their learning project. We have had the benefit of having student interns pretty frequently, and now that we've been through hopefully the worst of COVID, we're back into the student intern mode, and hope to continue with that. Our second goal will be to accomplish as we incorporate a new line of questions into our basic intake and screening tool. And this will trigger indicators that will either prompt immediate action or identify service needs that may not have been prompted by the call. It is our intent to work with the Department for Aging and Independent Living, which is our state unit on aging, so the impact is statewide, not just region-wide. So the current screening tool provides key indicators related to food insecurities and activities of daily living, but it's missing areas such as access to transportation, housing and utilities, health and wellness, and interpersonal safety. Through researching the current needs and knowledge of current trends in the aging and disability fields, our goal is to create new programming that can be incorporated into our historically provided services. This new programming includes falls prevention through a home modification checklist that is done with the initial assessment and once a year through reassessment. Food insecurity and food deserts will be targeted by adding a monthly senior commodity box of food with their normal meal delivery. This is now a possibility as our main meal provider is sharing warehouse space with our commodities program, which has really been a great partnership. And then this will be a year one goal for those whose indicators trigger health and wellness. We are working on expanding our nutrition education curriculum to include virtual options, which is a year 3 goal. Individuals who are at immediate risk for abuse and neglect will partner with our local transportation partners and with Emma to utilize SARA funds to get them to a safe space. This is currently available, but no trigger exists in our current screening. So enhancing this screening is really, really important. And we really want to work with the state on this because we have worked really hard to, to utilize a statewide screening tool. It's just very, very important. Goal number 3 will be contingent on how we accomplish goals number 1 and 2. Effective partnerships with those who are experts in the field of technology is key in how we access technology. Technology can address some of the aspects of isolation, but nothing replaces the need for human contact. I think we found that especially true during COVID and how it impacts our mental health status. I was just seeing on the news this morning how COVID has wreaked havoc on people's mental health status and on social anxiety and what people go through, have gone through in the last 2 years in regard to COVID. Telephone reassurance services are currently available through our senior centers, but there's still more that we can do as we begin to better understand how we stay connected. We will identify ways to meet this need, and it's really, really important. So then the question were, are the goals from the last plan period completed? I think we answered this question yes and no. So they were partially achieved. We have renewed our relationship with our local health department. That was done during the pandemic. In addition, and that has been very beneficial to us. I do want to add, I don't want to take up too much time talking about that, but that has been very, very beneficial to us to strengthen that relationship with the health department. In addition, we achieved a local food distribution site by combining the efforts of our commodities program and our primary meal provider, who now has a presence in Northern Kentucky. So it's really great now that our primary meal provider has a site in Northern Kentucky, and meals are going out of Northern Kentucky. Really, really a great thing. Okay, so moving on to 19, total number of program managers / supervisors. For us, that would be 5. Total number of program staff, 7. Total number of program volunteers, in-house and contract, that would be 105. Those volunteers come from Senior Center, Ombudsman, and also the SHIP program. Do all supervisors have access to computers? Yes. And all direct service contract have access to computers with internet access. These are just basic questions they ask us. How many new volunteers were recruited within the past 12 months? 14. And I need to make a note. Can you make a note, Stacy, under number 25? I need to write which programs. They were under all 3 programs, the Ombudsman program, SHIP, and senior centers. We had 9 new staff hired in the last 12 months under our waiver, home care, and ADRC. There are written job descriptions with all of our positions within the agency. We do conduct annual performance reviews for all of our staff. That's done in the September, October timeframe of the year. We do have plans to help our members increase knowledge or skills during the next year. We're always wanting our staff members to learn. So we offer opportunities for training. In-house training include webinars from community partners and membership organizations. So the webinars have really expanded over the last 2 years as we've gone through COVID. I would say training opportunities have been plenty. So M4A, SE4A, ACL, ASA, which is American Society on Aging, and the Traeger Institute out of the University of Louisville, all offer webinars. We hope to reinstitute lunch and learns, which is something we've done where we do an in-house, in-person training, where we bring in local people who provide training for us, and hopefully we can get that going soon. We also hope to offer external trainings at a local, regional, and national level. Starting to get out there and do that a little bit. I think that we have a local training coming up in April that we have a few staff that are going to, and it's been a while since we've been able to do that. So we are really excited about that. So how will we measure our progress towards achieving our overall agency goals? Oh, Shannon just told me I skipped something. Where are we? Oh, okay. I'm sorry. I skipped the number 32 or number 31. Do we have a plan to promote volunteer opportunities across programs? Specifically SHIP, senior centers, and ombudsman? Yes. Our SHIP and senior center operations are contracted to second parties. Our senior centers to various entities, and our SHIP program to Legal Aid of Bluegrass. They have plans to promote and retain volunteers within their respective programs. The ombudsman program is operated in-house. We have ongoing recruitment for ombudsman volunteers, and the ombudsman staff work on recruiting and other staff promote ombudsman volunteer opportunities when we have individuals inquire regarding volunteer opportunities inside of our agency. We are looking to expand our ombudsman team and incorporate a new contract position that is focused primarily on the recruitment and training of our friendly visitors. And the goal will be to design a training that will support our current volunteers and our ombudsman, as well as at least one friendly visitor in each facility in our region. A big goal, but I think a really good goal, and I think one we can attain, definitely. Recruiting volunteers will continue to be a challenge if the COVID-19 virus continues to be an issue. Part of our goals over the next 3 years will be to look at ways that volunteers can fill the gaps in expanding our telephone reassurance program at senior centers through peer support, as well as creating virtual opportunities that are peer-led, that will give seniors an opportunity to connect and volunteer at the same time. So really, really important. How will we measure our progress? So our overall agency goals will be reviewed on a monthly basis. We have monthly division meetings. Our contract services will be monitored on an annual basis through our annual monitoring progress, but updated at a minimum of biannually. And our senior centers meet on a quarterly basis. It will be a standing topic to be discussed and reported on. Our ombudsman goal will be evaluated monthly once this position has been approved and filled. So this area plan, most of this information in the next section, the area plan section, will be filled out after today. Although obviously it shows the time and the date, 2/22/22, 9 a.m. via Zoom. Excuse me, and live stream on our YouTube channel. And we did have the area plan available for review on 2/14, give people some time to look at it. And then everything else will be filled in after that. It'll be a couple days. By the end of this week, we'll have that ready to go. I'm going to hand it off. I've been talking a while. I'm going to hand it off to Shannon for certs, and she's going to talk about service usage, participant feedback, and satisfaction, coordination, and collaboration.
Great, thanks.
All yours, Shannon.
Fabulous. So in this next session, the information that you're looking at is directly derived from our most recently concluded needs assessment. And the information that we found and that we shared with our last Council on Aging meeting was very interesting. And so as we had talked about in that meeting, the state required us to either, they were going to come up with a statewide needs assessment, or the AAAs needed to. And so the AAAs decided we wanted to take that task on, and we created this statewide needs assessment. And so as the information came in and we began to break it all down, some of this information should be very familiar to you, but some of this is probably going to be a little new. And so to start it right off, the very first most frequently identified need or gap was actually falls and accidents in the home. And so that became a really, really interesting thing. It's not a question that we had historically asked, but what we found out of all the respondents, we received the highest percentage of responses to, are you most concerned? Are you currently concerned? Or are you concerned for the future? And falls and accidents in the home was our very first one. The good part about that is that's actually something that we've been talking about internally as program staff. And so we actually already begin to have some goals and objectives that we'll talk about a little bit later related to how are we going to meet that goal. In-home services was number 2. This is all things home delivered meals, personal care, homemaker services, respite services, those services that are our traditional services. And then the very last one was information. And this one, when you operate a aging and disability resource call center, becomes a really interesting one, because we did over 10,000 calls last year where we reached a lot of individuals, but there's still so much more work to be done. And so information and how we get that out, how we communicate that, and the methods and the ways that we do that becomes extremely important. So we're going to continue to work on that as we go. Our strengths and our service delivery, for sure, have got to be our meals. Historically, the state of Kentucky has made meal provision its main goal. And fortunately for us, we have a fabulous set of meal providers who also just eat, sleep, and breathe meals. And so that continues to be one of our greatest strengths. We look to partner with them in a lot of different areas. You're going to see how do we utilize the congregate meal program within our senior centers, and looking at really working with our meal providers on how do we make that a great program, breaking down the barriers. Why do people attend? Why do they not? We're also looking at expanding some access points to our rural counties. It is really expensive to get a hot meal into a rural county. And so we are piloting a project in Owen County that we're just in about the first quarter of rolling that out, where we are operating warming units in our senior centers. This is going to be fabulous because meal drivers now are located in that county. They go into the senior center and then they deliver. So while we have up to 4 hours to deliver meals, we don't need 4 hours to deliver meals, because now that hot meal is already generated right in that county. And then it's just simply however far out those individuals live. So we are really looking forward to seeing what the ultimate cost is, cost savings, efficiency savings that we're seeing there. And then again, you've been hearing a lot of us talk about incorporating commodities distribution into our meal routes. This is something that we've started talking about. Obviously, for our meal provider, they're just working through the logistics of transitioning their distribution center from Ohio to Kentucky. But we have been talking about this and are super excited to see how this is going to potentially roll out. We know there's a number of individuals who need a lot of food support, and but they don't have access to be able to get to a food pantry. And so how do we incorporate this wonderful warehouse of food into their home? So for sure, that is our number one strength in our service delivery. What's the weakness? Oh, goodness gracious. Right now, our in-home service providers are feeling this something terribly. And we are just struggling with the lack of aides and caregivers who want to go into this business. I know everybody has felt the need of either a really, really long wait time trying to get into a restaurant. How many times have we gone to, a Kroger or grocery store when, maybe those items that we're used to seeing are not on the shelves? Across the spectrum, we're having a workforce shortage. And so it hits terribly hard for our in-home services. It is not a service that we value as much as what we should. And so we are continuing to work with our provider network, trying to help and offer solutions that help them and also help our clients. Transportation is also another one of those weaknesses. In the third largest region in the state of Kentucky, our transportation options are very limited. And so what we are excited about is to be able to work towards a regional transportation system. Software is the key to that, and that has just recently been obtained. And so we're working on the partnerships that would enable all of the current provider networks who's providing transportation to share basically the information. So if, a transportation provider A runs into an issue where, they can no longer pick up their next person, that there's another vendor that's transportation provider who's out there who may be a lot closer, and we can switch that over to that individual, and that transportation provider can get that individual to where they need to be on time. So we're looking at doing that. And then also we talked a lot about our interactive website and division rebranding. The website is an agency-wide, a Northern Kentucky Area Development District project, but we are very much partnering in and working towards making that as interactive as possible. For those of you who have visited our webpage, you know that it's just not the most engaging webpage. We understand that. We're working on that. So our 3 most utilized services, number 1, our Aging and Disability Resource Center. Again, we talked about that, over 10,600 calls. So we know that our call volume continues to increase. It has every single year since the existence of our call center, and we continue to expect those numbers to increase. And as Ann talked about earlier, we're also looking at ways that we can really fully engage our call center staff on identifying those triggers and those social determinants of health factors, and how do we really address those and work with our other community partners who are the experts in those fields. Food support, absolutely. It has always been a high need. As you see here, we provided over 200,000 meals last year, and we continue to provide a tremendous amount of food support, but there's more that we need to do there as well. COVID definitely brought out of the woodwork those individuals who don't need case management services, but definitely needed additional food support. That has been one of those, I just kind of call those our hidden seniors, individuals who, you know, for the most part are able to do those basic in-home type of things, but they just need some additional food support. So we're working on that. And then number 3, our in-home services. Again, some of this is just we've been in the business for any amount of time. These are very identifiable service needs. And so we continue to work hard to address these. What we're again finding though with our in-home services is that our waiting lists are increasing. Funding at some point will be an issue. It's not currently, but we can't pay. It doesn't matter how much money is there if we don't have workers to do that. So we continue to look at that. What are our 3 underutilized? And this is going to be services for home repair, chore, and in-home respite for a variety of reasons, all of which we're looking at ways to expand. So home repair, here we were talking about, you know, establishing the need, the cost, and the lack of providers. While this is both home repair, chore, and respite are services that we offer and that we contract for, if we have individuals and our providers who are already just struggling to get aides and caregivers in the home to provide homemaker and personal care services, home repair becomes a luxury, chore becomes a luxury, but these are things that we absolutely need to focus on. Interestingly enough, again, home repair and taking care of their homes were also identified in our current needs assessment. So how do we look at that and work on that? Fortunately, we've got some great providers who are out there concerned about those same things. Conversations that we've currently had with the Center for Independent Living Option is how do we identify this need, not just simply for our senior population, but for our disabled population as well. So we're going to be partnering with them in these next 3 years on ways to identify how we can take this service as an underutilized service and really expand upon it. Chore service. This is a tough one, very specifically because of the work shortage and limited funding. Chore is those heavy duty type cleaning. And so this is where Ann spoke about our volunteers and getting individuals and groups to come out and do. Again, COVID has not helped with this because a lot of chore is in the home. We found a lot of our seniors, while they're missing that context, still were very hesitant on having individuals coming into their home. So we will continue to work with our current provider network, work with those volunteers and individuals who are interested in being able to provide these and making the connections based on the need that we see. Our in-home respite, again, this is a direct relationship to the worker shortages as well. The amount of time that an individual goes and spends with an individual care recipient, giving that caregiver that needed time and break is extremely important. And so We're going to continue to look at ways that we can empower and educate our caregivers on, either ways that they can provide breaks themselves, ways that they can help provide that service to their care recipients and still help and encourage them to do what they need to do to take care of themselves. Literally in a conversation we had with our caregiver coordinator, she said, my number one goal is to remind our caregivers that they need to take care of themselves, because if they don't take care of themselves, they're not going to be able to take care of their care recipient, their loved one. So whatever we can do to get into the home to help support them in that is also what we're looking at doing. So our participant feedback and satisfaction, how do we do this? Well, we do this on an annual basis. Every single one of our providers are required by contract to send out satisfaction surveys. As part of that satisfaction survey, when they send it out, the information comes back in and they react and respond to it. And that's all part of the monitoring process. So we're seeing that, we're receiving that feedback. Likewise, internally, we do our own satisfaction surveys. So the information that we are getting there is what is the biggest impact that we're making. It is extremely hard to develop outcome measures related to case management services, but satisfaction surveys help support us in knowing that we're making a difference. And so these are the various ways that we do client satisfaction surveys. So again, what do we do with this information? We take it in, we talk about it, we process it, we look at it. How does it fit in with our current plans and scopes? Does it require a change? Is it offering something that may be a little more efficient? Again, we take all that information and we begin to talk about it and incorporate it into what we're doing. We do have a formal process to investigate complaints as well as to respond to those. All of those are set up by the Department for Aging and Independent Living standard operating procedures. And so if you're interested in what those look like, please shoot us a message in the chat and we'll be sure to point you in the right direction.
Yeah,
Great. Okay, wonderful. So what are our procedures and methods for ensuring services are delivered in a coordinated and efficient way? And again, there's a lot to read here, but the very first way that we do that is making sure that our service coordination begins right at the very beginning through our front door, through our Aging and Disability Resource call center. From there, the initial screening is done, the resources and the referrals are made. And depending upon how that call is triaged, just depends on where it goes from there. The next process, once an individual has had that screening and they've been identified in whatever service, notification is sent to each one of those service coordinators, and from there just depends on what that service is. If they've been identified to need waiver services, and the question is asked, do they currently have Medicaid? Are they already approved for a waiver? If they're not, then they go through that track and getting that process started. If they need in-home services through our home care program, then it's there, and we are going there. Both ends of those currently have waiting lists, and so we don't just leave somebody sitting out on the waiting list. We have where we do at least a quarterly callback, just making sure that things aren't changing, and if there's something that we can do in the meantime, we're going to do the best that we can in getting that done. Our personal care attendant program services is a little bit different. Oftentimes there's a tremendous amount of conversation that goes back and forth. Somebody maybe calls our Center for Independent Living option. They'll talk them through all the things that they offer as that provider, come back to us, and then go through that process. And likewise, if they're through us, then we make the referral over to them, again, where those conversations happen. So we do a lot of that through technology, which helps make it real-time information. And it also allows us to track and know how long somebody's there. So coordination and being efficient becomes very important in what we're doing, making sure that all of us are on the same page, talking. And so consequently, there's a lot of conversations that do happen internally. So we do have plans to improve that. And again, maximizing efficiency and analyzing procedures. And you will see that one of the other ways for us to do this is to take a complete revamping of our current internal policies and procedures manual. We're starting that out very methodically. That's going to be a goal that you're going to see us coming in through here, but there are other sections that we also will talk about. There's a whole goal section on what makes, what are we doing to make sure that we are optimizing the services that we provide. And again, we're going to measure those exactly the same way as we measure everything else. We are going to be just reviewing these, making sure that we're addressing complaints. We see satisfaction surveys that are coming back incorrectly. If we're finding that processes are taking too long, constantly looking at ways that we can do our job better.
Okay, before I review outreach and expansion, I wanted to take this moment to ask if anyone had any questions so far. We are more than halfway through, and I just wanted to give the opportunity in case someone had a question. I didn't want to hold all the questions until the end in case somebody had to jump off early. I wanted to give an opportunity right now. I know there are a couple of questions that have popped up in the chat, but I wanted to give everyone an opportunity now. If you had any questions, you can ask them. Anyone have a question on anything we've reviewed so far?
Well, Anne, this is Laura Plyman and Shannon. I did put it in the chat, but I just wanted to clarify, if you don't mind. Back, I think, really early in your presentation, you're talking, I think it was page 7, you were talking about the clients who received, you did a breakdown of demographics and clients received home care, Medicaid funds, things like that. I assume that's based upon your actual service provision, not census data, correct?
Yeah, Laura, the only information that is related to census information is the, go back to the profile for your region, section 3, it's 4, and it was literally the one that just had the percentage of persons 60 and older, regions population over 60. That section right there is very much census data, and that all of that census data has not been updated, well, at least at the time that this is published. The other percentages, funding sources, that is very specific to our funding source, yes.
So you're tracking English proficiency and things like that, and I didn't know you guys tracked that particular piece based on funding source.
As far as, so those other new questions, those 3 questions that that were asked on, I guess it's page 9, talking about that, where it's talking about limited English proficiency there.
Yes.
Yes. So, so what happens there is we do ask certain questions and within our assessments that do indicate, you know, what is your primary language, and so we are and do have the ability to report on that. It's information that is required by the Older Americans Act as far as one of those areas that we have to do. So yes, and it is very, very, very small.
Great, thank you, appreciate it.
Sure.
Anyone else? Okay, we'll go ahead and talk a little bit about outreach and expansion. The next question is, do you have plans to connect outreach with those with the greatest economic and social needs, with particular attention to low-income older individuals, including low-income minority older individuals with limited English proficiency, older individuals with disabilities, older persons with limited English, and individuals residing in rural areas as specified in the Older Americans Act? The answer to that is yes. We are held to the provisions of the Older Americans Act, and all of those things are required. So we continually look for ways to outreach to these specific population groups. Our goals listed above address ways in which we provide much needed outreach in our region, and we continue to look at ways to engage our first responders, minority groups such as the Hispanic population, rural non-contracted local providers, and continue to increase partnerships with the larger disability networks. So we are always looking to expand our purview so we can outreach to all of the required groups, to those with the greatest economic and social needs. So how we'll measure our progress is through our front door. So the calls that we take in our ADRC, setting some baseline data points at the end of this year will allow us to measure our progress for the upcoming years, and we should see the number of community partners increase too. So those are basically the two ways that we'll see the improvement in that area. Do we have plans to increase the visibility of our area agencies on aging services? Absolutely, we do. We've already begun to do this. We know there's a lot to do. So that starts with our division, which for years and years and years, our division has been called the Human Services Division. And recently, we changed the name of our division. So now the new name for our division is Aging and Disability Services. We just got the blessing, I think it was about 2 months ago. Right, Shannon? Yes, 2 months ago. That it is what we do. It better identifies exactly what we do. That is the way we are identified here at the Area Development District. So our new mission statement, which I mentioned earlier, we provide resource solutions and services focused on improving the quality of life for older adults, caregivers, and those with disability. Those with disabilities, we will put that at the bottom of our email signature line, and it'll be listed on all of our new brochures and business cards. And we're working right now, our staff is to create a tagline and a new logo that will connect who we are and what we do. We're also looking for ways we can develop services that we can build into our current menu of services. So we are looking to to expand our service line. We're looking to make ourselves more visible in the community, and all of these things that we have, all these changes that we are making are very purposeful in doing that. How we'll measure our progress. We've already feel like we've made progress, but it'll be continued as our new logo and tagline are developed. We need to do a major revision on our brochures. So we're hoping to have those available in different languages and then digitally on our website. And then new services being developed will be reviewed during our monthly division meetings. And they should not cost anything to provide, as they would be offered as a part of our normal services. And they should identify new gaps that we need to address and or new partnerships that we need to create. So all exciting things that are happening. We're super excited about the change that's going on. Change is good. It is really good. So a little bit about community opportunities. How many of the counties in your service area have at least one focal point? And that is all 8 counties. What services do the focal points or multi-purpose centers typically offer in your region? All focal points, multipurpose centers, and we're referring to senior centers here, are required to provide the following services: recreation, outreach, information and assistance, health promotion, education, which also includes nutrition education, which has become very, very important for us. And I will note, because we've talked a lot about telephone reassurance, that that is an optional service. We do have plans to improve and expand our senior center services. And those plans have to do with direct correlation between proper fitness, proper nutrition, and proper education that can lessen the potentials for falls, onset of disease, and access to services. These services will be provided in a coordinated effort to enhance the overall connection between these services. We'll also enhance the experience of the hearing impaired, both current and potential senior center participants, with the availability of assisted listening devices at each senior center. Very exciting. Expand virtual programming through a platform, which I mentioned in our community partnerships, Burn Along, for health promotion requirement for both senior center participants and senior adults with overall community, and expand outreach efforts in partnership with senior centers and other aging program managers to address social isolation amongst senior adults in our community. Social isolation is a big problem, and we continue to try to address that in our communities and among our seniors, and it's only gotten worse with COVID. So how we'll measure our progress is we will pilot the innovative programming and measure progress on a set schedule, and we'll make any adjustments. The number of unduplicated participants in SAMS, which is our aging software, will provide direction as to how many we are currently serving. This will allow us the opportunity to enhance and expand our outreach services. Do we have a community education plan to increase long-term care planning among older adults and individuals with disabilities to remain in their home? And that is yes. And we are committed to educating the community regarding our programs and services, as well as matters to long-term care planning. Although a lot of those community educational events have been postponed due to COVID, we hope to resume this soon. We've had partnerships with organizations and participated in events such as end of life education, which include all sorts of issues, wills, organ donation, DNR, and other issues around pre-planning. We've done a lot of that, and we hope to continue that. Do we have a plan to improve or expand our training with our staff? Yes, always. So as I mentioned before, we always look to increase training with staff, successful and engaging with trainings through N4A, ACL, American Society on Aging. In addition, SE4A, which stands for the Southeast Association of Area Agencies on Aging, has launched a new webinar series on a variety of subjects, and staff has participated in this and have gleaned a lot of information. It's a monthly webinar series. We also participated in the Traeger Institute from the University of Louisville Project Echo training series, which we actually presented a case study at that. That was really exciting. And then in-house trainings, lunch and learns, which we hope to, as I mentioned before, we hope to resume. Providers are responsible for required training, for required training hours for their employees, and quarterly training for senior center directors is generally provided. Okay, and how will we measure progress? By attendance and evaluation of training. We always evaluate any training, and participants are surveyed during in-house training to see if they've increased their knowledge base on information they have received. center managers provide both formal and formal feedback on training topics they have for their quarterly meetings. And staff who have annual training requirements will meet that goal. So that's how progress is measured. Excuse me, just a second. Okay, and the last part of this section that I'm going to talk about is information and referral. So does your agency maintain and staff a separate information and referral line? Yes, we do. The ADRC number is a separate phone number. There's also an 800 number connected to that, and an email address. So for those of you who are wondering about that. How do we advertise or market our information referral system? We use numerous methods. Our resource counselors attend community events to promote the Aging and Disability Resource Center. They do presentations. Those have been a little bit not as frequent right now because of COVID. But as you can see by the numbers, it really hasn't hurt our numbers. Our numbers continue to grow and grow. But when they do provide presentations, it's to senior housing facilities, hospitals, and community organizations. They do mailings to individuals and professionals with our brochure. We also do a full page advertisement in the local Older Adults Resource Guide of Northern Kentucky, which is generally distributed to about 10,000 people in Northern Kentucky. And the 2022 guide, when we look at Shannon, probably in the next 2 months, the 2022 guide will be coming out. They're working on the final stages of that. And the ADRC is listed in numerous sections throughout the guide, and it's a primary resource information and assistance. The ADRC has also been the major distributor to the guide to many professionals. So I know that there are some people on this call that we supply guides to, and we keep them here at the Area Development District. So if you're interested in receiving guides, let us know. We have those. We are a primary point of contact for those guides. On average, our ADRC handles about 920 calls a month. And we do a client satisfaction survey process for the ADRC, and we always look to improve that information referral process. Plans are in place to incorporate a document into our website that will allow direct referral to be sent to our ADRC. This will help us with to eliminate duplicate entries due to misspelled names or what have you. So we're hoping that will come to fruition soon. The next goal would be identify those agencies that we make the highest referrals to and sit and talk to them about how we can best track those referrals. That we can best track those referrals if they were followed up. So we do a lot. We have a lot of not just individuals who call, but a lot of organizations that call and make referrals. So we do really want to target those organizations. We've also been talking to the Health Collaborative to determine if they can assist with this type of data exchange being done with their current program. So they already have a data exchange program, and we're looking at partnering with them to hopefully enhance that process. And Shannon is next. She's going to talk a little bit about financial management.
So do we have enough adequate funding to meet our community needs? No, the answer is always no in that question. And for those of you who provide services, you should laugh and say no as well. I will say that right now there has been more money than has ever been available based on all of the COVID incentives. Unfortunately for us, access to the use of those funds beyond meals has been very much a challenge, and working with the department on, thinking outside the box, creating new programming, but then sustainability. And so conversations that we have with them around that are, if we're thinking outside the box, then we're not already utilizing the current wheel that's been in existence. We're creating something new. And in order to create sustainability, I need to see if what we want to do is going to work and to be viable for sustainability. So those become a lot of the conversations that we have with them. But in general, do we have enough current funding? No. Again, we've got individuals who are waiting right now on the waiting list for almost a year, maybe even at this point a little bit over a year. And these are individuals not waiting for meals. That's the beautiful part about all the extra funding. We do not have anybody who is waiting for a meal. But if you need homemaker, personal care, respite services, there is not enough money to support everybody who is on the waiting list waiting for those. And if that wasn't even an issue, again, we've been talking a lot about our aid and our caregiver shortage, and that does make it even more difficult. So it becomes a balancing act. How do we get individuals to be interested in providing these services? And then once we do we have enough funding to sustain that? So it's always been a balancing act that we've had to manage. It's just COVID has definitely made it a little more of a struggle. So providing an explanation of how the program income fees and donations are collected and used to expand services. This really has not changed. It's the exact same process. For individuals who are in our home care program, these are individuals who are receiving state funded services. We do take a look at their resources, and depending upon how all of that comes out is determined whether they are asked to provide a portion of that via a program income and a fee. And so if individuals meet that, then they are then required to pay a percentage of their services. If you are required to have this and you're receiving personal care, homemaker, or respite services, then that fee is billed directly from the provider. And what happens is that as they collect those monies, the providers report that to us, and we subtract that amount from the reimbursement. And so basically all of those fees go back in to help expand the programming that we're utilizing. For our senior centers, and for our meals, and those programs who do different donations, those funds are reported to us, but they go directly back into the programs to help that programming. And so again, they have to report it to us, and at various aspects they're able to expand services, especially for our senior centers. Maybe they're able to get some new technology, some new materials, things, that require the senior centers to operate effectively as well. Individuals who are participating in our meal program, again, those dollars go back into the meal program to offset those meal costs, which then allow our meal providers to be able to go out and continue to provide services, and use those extra dollars to help support matches and get other funding, and very specifically because of the partnerships that we have with our meal program. As an example, our shelf meals that we made available for our winter are isolated individuals who are just receiving hot meals or very, very difficult to reach individuals in that inclement weather. Our meal provider came on top of that and said, hey, while you guys are taking care of those, we're going to provide 2 extra meals for everybody else. That's what happens when, you know, the donations are collected and put back into the program and they're able to expand it. We appreciate that. So do we have a plan for increasing that? Absolutely. Some days we're a little more effective in that, and other days that we aren't. But we always have some type of a plan that we're looking at doing. And so very specifically this year, in the next 3 years, is going to be targeted towards transportation. It is expensive if you want to take public transportation using a private method, and Uber and Lyft, and those type of avenues are there, but they can be very expensive. Individuals who need medical transportation, especially if you're in a wheelchair, can cost anywhere from $30 to $75 one-way trip. That's a lot of money. And so how do you get the cost down? Well, you get the cost down by basically sharing what's out there. And the only way that that sharing is going to be able to be done is through technology. So we are partnering with Owen County Transit, who offers both medical and non-medical transportation. They have purchased the software, and KADD is in the process of identifying and hiring through some other grant funding that we've received to get a mobility manager position whose main goal is going to be completely invested in this software, love it, learn it, breathe it, and then go and market it to all of our other transportation providers. So that, again, as I've mentioned before, as we have opportunities that individuals need to go, if we are streamlining and making efficient the routes that we are currently on, it will, in essence, drive the cost down. And hopefully we will be able to start offering not just simply medical transportation, but that so much needed social transportation that isn't just simply via tank and those fixed routes, but we have access to it from all of those other ones. But this requires us to all sit down at the table and coordinate that. And so that's part of this plan as well. Tank is a big part of that. Owen County Transit, FAWAC, Shaven, some of our for-profit, Executive Mobile. These are all the entities that we are going to be talking with and trying to encourage to join this partnership. Our financial report shared with the Council on Aging and board members, absolutely. And we do that on quarterly, and sometimes depending upon how that works, about every 4 months for sure, biannually, and then every year there is an annual comment and time that we present that information. How do we provide for equitable allocations? This is a really, really long process. I'm not going to read everything that's in here, but it is based upon a lot of different information. So the initial screening, that the initial dollars come in. We take a look at what was done the year before. We try and track what is waiting on the waiting list, and then, you know, do we need to make some adjustments, pluses and minuses here and there. Once we kind of identify the pots of money that go to each one of these services, then it kind of goes from there. If it's going into our senior centers, then it depends on what type of senior center that we have, the numbers of individuals that they are providing services to, and that's a whole separate process. For our in-home service providers, it is a competitive process. So we do not contract with a specific dollar amount for a specific service to a specific provider. We have found that going and doing it this way ensures healthy competition between all of our providers, and also allows maximum client choice. How do we address the county need? We know that that's been something that has been something that we need to be paying attention to. We understand that our rural counties do not have anywhere near the population that our urban counties do. But we also know that the number of services available in our rural counties are not anywhere significant as to what they are in the urban counties. So how do we have a balance? A lot of that balance is actually done through the screening tool and somewhat taken out of our hands. When an individual comes into the program, into the software, the screening process, based upon their need, they are given a number. That priority number helps us to look and see how do we need to pull individuals off of the waiting list. What we then do is incorporate what are those percentages that we are actually doing in our urban counties, and what are we doing in our rural counties, and then balancing what that looks like. Again, for the meals, it doesn't matter, which has been really nice. Right now, honestly, what's dictating a lot of in-home services is where is the aid available. So right now, we've got a lot of folks that are waiting in our rural counties because we just have they're not just simply not access to aids, that there isn't any even on the radar screen. So we look at how do we balance all of that. How do we ensure that all funds are expended? They are monitored on a monthly basis, for sure. The Department for Aging and Independent Living, through all of this COVID stuff, has actually started doing, which about a year ago, they were doing almost monthly phone calls with us to see where are we in each one of our program areas, each one of our service areas, and are we on target, are we on track to spend those monies? A lot of that had to do very specifically with the meal program, because at one point in time, we have a handful of our counterparts who are way over budgeted in their meals. We are not. That's a really good thing for us to be able to do. Now we are meeting on a quarterly basis. Then again, we also report to our Council on Aging. So at every turn, we are looking to make sure, are we spending these funds? And if we're not, why are we not? How do we ensure that the operations of the program in the absence of funding or overspending or inadequate? Again, monitoring, as I mentioned here, is the key. If we are looking at all of this information on a monthly basis and we are making adjustments, then we should never really be in this situation, or it should never, if it's underspending, then we should know exactly why. If it's overspending, then we should know exactly why. And because of the amount of review that we're spending and the conversations that we're having both internally and externally with the state, we've been able to identify all of those areas that are either over or under, and then making the adjustments as we need to. If funds are not expended, what do we do with the remaining funds? Well, now that's an interesting one. If there are remaining state funds, we don't get to do anything with them. They go right back to the state. So spending our state funding first, and the state understands this, is our priority. So if a service has both federal and state funds, we are going to spend a greater percentage of state funds first. My goal is to make sure that we spend all of our state funds before the last month of the fiscal year. In programs that are fully state funded, obviously we go all the way through, but we are looking to make sure that those funds are spent. For our federal funds, we actually get the privilege and the benefit of having those carry over into the next year. Now that becomes a tricky carry over because we have to go through an auditing process. So if we have funds that are underspent from the next year, that funding cycle ends, or that year ends in June, we don't normally get access to those unexpended funds until about February, March of the new calendar year, which then means, if we have a ton of unexpended federal monies, you have a very short amount of time to spend those. So even in that, while we have the ability to be able to use those funds in a new year, there's a very time-limited capacity with that as well. But again, all of that information is presented to both our council and our board.
So I'm going to talk about the program site monitoring. All of our monitoring our in-house evaluation is completed in accordance with our contractual obligations to the Department for Aging and Independent Living. So all of our contracted providers are monitored at least annually. I say at least because some of our providers are monitored twice a year. So program staff and myself are responsible for the monitoring. Also, our case management monitoring home care in Title III is completed by the case management supervisor, Stacy. She monitors on a regular basis and reviews the charts of the case managers to ensure that the work being done is quality work, and she looks for trends and issues that come up within the case management files. So that is done on a regular basis. We have a quality assurance manager in our waiver program, very complex program, and she is responsible for all of the quality management within the waiver program. So that is a continual process. Other methods, evaluation occurs through staff supervision, our monthly division meetings, case management meetings, and other process where we are discussing programs and services. Program staff meet with myself or Shannon to discuss ideas and thoughts regarding implementation. So we monitor a lot. It goes on as a continual process. I feel like that we're always reviewing and monitoring the things that we do. All right, on to goals. What I'm gonna do is I'm gonna read our goals. I'm not gonna read the goal narratives, but I'm gonna go through our goals, and then I'm gonna actually go through our strategies and our objectives and strategies for the first three goals, and then Shannon, I'll have Shannon go through the goals or the objectives and strategies of the last three goals. Does that sound okay, Shannon? Okay, so our goals, and there have been some slight changes. Again, these goals are designed by the state, by the Department for Aging and Independent Living, but we develop our own objectives and strategies to meet these goals. So we do have free reign on that. So I'm going to read all the goals. So goal 1, provide long-term services and supports that enable older Kentuckians, their families, caregivers, and older persons with disabilities to fully engage and participate in their communities. Goal 2, ensure older Kentuckians, persons with disabilities, caregivers, and their families to have access to person-centered planning and option counseling for their long-term services and supports. Goal 3, increase the development and implementation of business-related strategies that promote innovation, collaboration, and sustainability of aging and disability network partners. Goal 4, prevent abuse, neglect, and exploitation while protecting the rights of older Kentuckians and persons with disabilities. Goal 5, ensure continuous quality improvement principles to ensure the Area Agency on Aging and Independent Living operates efficiently and effectively. And goal 6, ensure that all Kentucky elders and individuals with disabilities have equitable access to services regardless of any social, cultural, or geographic barriers. So I'm going to go through our first goal, actually the first three. So goal 1, being to provide long-term services and supports that enable older Kentuckians, their families, caregivers, and persons with disabilities to fully engage and participate in their communities. So our first objective within goal 1, and we have several objectives, bear with me, is to update the agency website to promote easier access to resources and referrals. And our strategies work with current partners who publish older adults guides to include a live updated version of the guide via our webpage. The second strategy is to develop a web-based referral tool that can be sent directly to our Aging and Disability Call Center. Some of these things you've heard mentioned already. Objective 2, identify and engage isolated older adults and caregivers with disabilities. Our strategy is to identify isolated individuals in our community and to create a volunteer-based program that is operated through our local senior center that engage identified individuals, engage identified isolated individuals. Our third objective is to expand the core services provided by low cost program options. And that is the first strategy is to develop an evidence-based prescription pad that will act as a referral source for local evidence-based strategy, develop a home safety checklist that will identify potential fall risk and home modifications, and expand our nutrition education curriculum to be available in the home via podcast, YouTube, and video options. Identify and expand evidence-based programming for our region and develop an in-home falls risk tool that will quickly identify potential fall risk upon the first home visit and assessment thereafter. Our fourth objective within the first goal is to develop and promote emergency preparedness from the individuals and families in our senior centers and group settings. And the strategy for that goal is to work with the Northern Kentucky Emergency Preparedness Committee and to have annual presentations on how to prepare for emergency in our senior center and other group settings. And objective 5, disseminate information on the current trends, topics, issues, and resources into the community. Strategy, in-home team members will provide clients with information on trending topics affecting the older adult population through the mail or while in the home. And our staff, ADRC staff, human services, program staff, and case management staff will all be responsible for completing that goal. Goal number 2, ensure older Kentuckians, persons with disabilities, caregivers, and families have access to person-centered planning and options counseling for their long-term services and supports. Objective, identify social determinant of health risk factors and incorporate into our intake processes. Strategy is, first strategy, work with Department for Aging and Independent Living to incorporate additional questions into level 1 screening tool that identify risk factors associated with social determinants of health. Review current systems to determine gaps in proper tracking of these risk factors. And the third strategy is to identify resources that are available and needed once a risk factor has been identified. The second objective is to expand our client care plans to include specific goals that the client has identified during the initial assessment as the goals are accomplished and annually at reassessment. Strategy is to discuss the goals set at the monthly phone calls and document them in the statewide database, which is currently known as SAMS. Our program staff and our ADRC staff and case management staff will be responsible for that. Goal number 3, increase the development and implementation of business-related strategies that promote innovation, collaboration, and sustainability of aging and disability network partners. And our first objective, address food insecurity for those who have transportation issues to access commodities or other food resources. Strategies would be to develop a program with our commodities program that will identify a box of food items to help meet older adult nutrition requirements based on the current senior food commodity program. That's the CSFP program. So it would be a CSFP-like program. Establish a volunteer program needed to put food commodity boxes together. Work with our local meal provider to incorporate commodity distribution into daily meal delivery. Our next objective is to increase the knowledge and access of home modifications assistive technology information and home repair services. Strategy, develop an assistive technology store where older adults, caregivers, and other disabled population can test the products to determine their effectiveness. Work with the Center for Independent Living Option, develop a listing of providers who specifically work with the older adult and disabled population to provide home modifications. Develop contacts and resources that aid with minor home repairs and services for issues for promoting safety and security in the home. This includes both paid and volunteer contacts and resources. Our fourth objective, increasing the funding for case management services, research and develop a plan to implement private pay case management and assessment services. And objective 5, partner with local law enforcement and first responders through Project Life Connect, which we mentioned. We'll identify local cities who have a social worker on staff as first responder. And then we'll partner with those staff and around the importance of Project Life Connect and identify ways to get the envelopes into the community. We'll identify funders with those cities to cover the cost of the materials and a person and groups who would help assemble the envelopes, because that is a big job. So it would be program staff, caregiver staff, ADRC, and case management. It's a big job and we need a lot of help. And Shannon is going to review our last 3 goals.
Great, and I hope that as Ann and I are going through these last set of goals, you're going to hear a lot of things that you've already heard above, because it's important in this plan, as we take opportunities to summarize and identify needs and weaknesses, that you see where we're either identifying or trying to strengthen and empower and recognize and meet those goals. We're really excited about them. Staff have been working very, very, very hard over these last really 6 months in trying to look at ways that we can continue to move forward. And I think the beautiful part about this plan is it's finally putting into paper ideas and concepts that we have all had as staff, taking a look and hearing and seeing. And again, as the data comes in through the needs assessment, validating what we've been seeing and really helping us to put into place the foundation that makes all of these goals, these objectives and strategies hopefully become reality. So our goal 4 here is to prevent abuse, neglect, and exploitation while protecting the rights of older Kentuckians and persons with disabilities. So our objective 1 here is let's just increase the visibility and contact with residents in our independent living, PC homes, and other facilities. That's kind of a standard goal that we have. But what are we doing as far as the strategy is concerned? Well, this is mentioned before. We want to create a volunteer program that is very much a training curriculum for our friendly visitors and our certified ombudsman. It's something that we have to do, but it isn't into the program that we want it to look like. So that's our first objective and strategy. Objective 2 is to educate and bring awareness of elder abuse to residents, facility staff, and other providers within the community. And here is where our provider network and community partners really come into play. So we want to utilize our senior centers as a place to distribute this information. And then we're going to work with our Elder Maltreatment Alliance to develop an education and training strategy that includes just more than the ombudsman. It's really easy for the community to just look at the area agency and our ombudsman and say, you guys are the experts, and we are, and we value that trust, but we can't do it alone. We have to have our community partners who share in this mission and in this vision that we have to get this information out. And just on a real quick personal note, my dad, unfortunately, was a victim of one of these financial scams that started with this laptop. So I'm going to be working with this Emma group to really get back to making sure that we're reaching out to all of those banks and other places where this is, because when it hits home, it makes you really want to jump into it and utilize it and do it. And these are 2 great places that we can focus on those strategies. Goal number 5, and here we talked about this before. What are we going to do to make our program work more efficiently and effectively? And so what we want to do is, number 1, let's start by streamlining our access points within our department, within the Aging and Disability Services Department. And so we're going to create one number to contact our ombudsman and to promote that number inside our facilities and inside our community. Right now, we're very familiar with our Aging and Disability Resource Center call number, but if you call the ombudsman right now, you're either going to get one of our ombudsman direct line. We want that to go to one central number that both of them can pick up on. That is a very easy number for us to do, and we're in the process of working on that, and that's going to help streamline how that information gets to our ombudsman. Our second objective is to provide updated resources in a timely manner. I think that's the one thing that we've seen through COVID is how do we get information out? How do we get it out timely, and do we trust it? And so what we're doing here is we're connecting with our older adults, our family caregivers, and those with disabilities through different social media, such as TikTok. We are super excited to begin to roll that out right now. If any of you guys are on TikTok, our intern, Quinn, this is her service learning project, is to begin to get that information out via TikTok. So if you go into that app and you do hashtag ADD cares, you're going to see some of the TikToks that we've done there. Stay linked into that. We're super excited with a completely different social media aspect that we've never really done. There's a lot to do. The website will also working through that. We are looking to have support groups virtually through Teams on a quarterly basis through our family caregiver program. And also the caregiver page of the newly designed website will include caregiver key concepts. Again, how do we get that information out there? These are going to have tips and tricks on ways that identify things that caregivers can do to empower themselves, to reduce that guilt, handle those family issues, and all things related to supporting all of our caregivers and the services that they're providing. We're also going to be looking at providing quarterly training opportunities in Zoom classes. And we also want to continue to work with Senior Impact to streamline the process to get our updated resource information into the resource guide. I do not know if any of you are familiar with the online version of that guide. Many of you have the paper copy, and that paper copy will continue to be vital to us. The delay that we've currently had in that has nothing to do with the information, but paper and that resource. So that's been why that has been delayed. But what we're looking at doing is working with them so that in real time, as we have information changing and we're notified of that change, we can send it directly to Senior Impact, and they can go directly into the online document and change that so it is in fact as real time as possible. Our objective 3 here is to maintain a consistent monitoring schedule, ensuring policy and procedures are met, conducting follow-up procedures and secure applicable action plans. So that is all things policies and procedures. And so we are looking to expand and update that manual and provide technical assistance and enhance services and correct our problem areas. It is always good to go back and make sure that what we're doing is what we should be doing, and it's the most effective way doing what we're doing. We're also looking at our objective 4 to identify programs that can be transitioned to all electronic documentation. We are super excited that we are beginning this process with our home care program, and all newly assessed clients are now going to be completely electronic documents. So when the state comes in to monitor, they don't need to ask us for anything. They're just going to go directly into the statewide database, and they're going to access everything that they need. It's going to take a long time. It's going to be a process, but we're super excited that we're starting that, and we'll really be able to get into it as this new fiscal year rapidly approaches. So who's all involved with this? Well, a lot of us, including our IT department, because they're the only ones that can get that ombudsman number done. As you can see, when we talk about effective and efficient goals within the division, it requires all of us to be able to get in there and do what we need to do. And the very last goal is ensuring that all Kentucky elders and individuals with disabilities have equitable access to services regardless of any kind of social, cultural, or geographic barriers. This is one of those areas that I just thought, man, we're social workers. We understand the importance of equity. And then I began to do a little bit more research and understand that even myself didn't fully understand what equity is and the difference between equality and equity is. And so there's a tremendous amount of space that, if me personally, I need to grow in this. I know my fellow employee or staff members do, and community does as well. So one of the first objectives is to advocate on behalf of those in facility settings to ensure they have equitable access to services. And we can do that again by participating in trainings that educate our ombudsman and our friendly visitors on what those inequities are within a facility setting. It's a completely different world, and they know a lot of the inequities in there, but how do they address it? And so that becomes extremely important as you have friendly visitors going in, and as we want to increase those numbers, we need to also make sure that we're increasing their education. We're also going to identify and enroll individuals in the community setting who need access to smartphones. This is a straight partnership that we're having with Legal Aid of the Bluegrass. This project actually began this last fiscal year where they were able to identify individuals in some of our facility settings, but we didn't get to all of them. So let's continue to expand that, making sure that we're getting access to individuals in those settings who need it, but not just simply there, because we know that there are a number of individuals who don't have access, who are still living in their own home, and maybe they just have a landline, which is totally fine. But access to those smartphones really does allow them to do so much more. Again, it's going to mark some needs, and we know that technology has its own issues, especially as it relates to smartphones. For those folks of you representing our rural counties on this call, you may even already have an issue with, do we even have access to it? Well, guess what? When we identify those areas where smartphones, we can get a smartphone into it, but we don't have any access to any of the cell towers. Well, that's information, that's a gap, that's a need, and that's where we can take it back to our big KADD board and continue to work with them as they're looking at the infrastructure within the region. So we're excited about the opportunities there. We're also going to increase our equity awareness to both staff and general public. And this is going to be just locating local and state and national resources and incorporating those into our social media outlets, into our webpage, just getting that information out there. If you were ever curious about what it is or what the difference is or what does it mean, we want to be sure and link you to those trusted and reliable sources and sites that are going to help you to have a better understanding. The last strategy in that objective is to identify our community partners who work directly with these populations who most frequently experience inequity. Man, we understand that there's a group of individuals that we are missing. When we talk about our, Laura, you mentioned it before, our limited English, and we're only talking about 1%. I know there's a lot of you who work with a much greater percentage of that population. We need to do a better job at reaching out to them. And the best way that we can do that is talk with the individuals and our community partners who work directly with them. We have to do a better job, and we will. Our objective 3 is we're going to create our virtual health and wellness opportunities by offering programs for any individual, regardless of where they are, their social, cultural, and geographic barriers. And this is 100% having to do with the relationship with the Burn Along platform that we're looking at. And we're really excited to see, again, this has a direct relationship with some of the funding that I was talking about before. We have to convince the Department for Aging and Independent Living that this is something that they need to release the money on. And that's exactly what we're going to be doing. So we're looking at, again, different platforms that break down barriers and making sure that they have access to some of this information. That also ties into the smartphone because you can access this on a smartphone. It all links together. So who are going to be working on this? Our ombudsman staff and our program staff. So we're super excited. Again, we get a little overwhelmed when we talk about all these different goals and objectives and strategies that we're doing. If you guys continue to remind us that we have 3 years, we'll continue to remind you that we have 3 years to work on this as well. It's a lot, but we really feel confident that we're going to be able to really get out there and do this and meet some needs. We're excited.
So I'm, if you want to just go back a little bit, I'm not going to bring up the performance plan forms because they're actually a separate document. But on the website, you would have seen those at the end of the actual area plan. So if you want to take a look at those forms, those are just forms that we have to fill out for the state to satisfy their requirements. It's just the Form A shows our Aging Advisory Council membership. Form B has our administrative staffing plan, and which shows all of our administrative staff within our division. And then Form C is our direct staffing plan. And then Form D is our provider direct staffing plan, which is any services that we contract out for. Form E is case managers. So it just lists the case managers and their credential. And then Form F is our SHIP counselor location. So where are our SHIP counselors located? Form G is our SHIP counselor details. So it lists all of our SHIP counselors. Form H shows who all is involved in our ombudsman advisory council. And then Form I is our provider site list. And the provider site list shows all of the providers that we currently contract with. Shannon is going to go through our special program approvals because there have been a few changes to that.
So we are, again, excited about some of the new changes that we're doing. This very first special justification is actually just talking about the change from hot meals to our frozen or our chilled meals that our mom's provider provides. This really has not changed from anything because it is different than the normal hot meal. Every year we have to put the same thing in here, even though frozen meals and chilled meals aren't uncommon anymore. They're actually in more number than the hot meals for a variety of reasons. So I'm not really going to read through this, but all of this basically justifies why we're asking that those are options. This one is a new one. And so what we are doing, as I've mentioned a number of times, is trying to identify what are the ways to overcome the shortages that we're having with aides and caregivers. And so as we've been having conversations with our providers, and let me just throw just a real quick shout out to them. They are working so hard and we appreciate that and we acknowledge that it is tough being in this business. The crazy part about it is that there is a tremendous amount of money to be made right now, but you can't make any money if nobody wants to do the job. So our providers are having to get out there and really sell who they are, our agencies, and the work and the jobs that they need to have filled. And so as we're talking internally, what are the ways that we can begin to do this? We also need to begin to look for the non-traditional ways that the service is provided. And so fortunately, we have two very good examples of how that works internally. One is through our Medicaid waiver program, and one is through our family caregiver program. Understanding that we are not trying to replace at any point or remove from existence traditional providers. They are vital and so important. And so I just want to make sure that that is a very, very clear understanding. But what we're looking and what we're going to be asking the department to do is to allow us a pilot. And as you see here, it's going to be very specific to the NAPAS 3B supportive services, homemaker, respite, chore, home repair, funding sources. And so what that does is we're looking for anybody who was either currently receiving services, but no aid is available, and they've been waiting for over 1 month for services to restart, or they were recently assessed for services, but no aid is currently available due to the location of their residence. Now, again, that's going to hit very specifically in our rural counties. We've heard from our providers that it is very difficult to get aids out there for a vast amount of reasons. So what we're looking at is if an individual meets 1 or 2 of those criteria, then we would like them to have the option to be able to hire their own provider. And so what that means is, in the way that both our waiver program and our family caregiver program works, that individual, their family, will locate a family member or a friend who is going to be able to come in and provide that services. And so once we get that person identified, then we've got to look at, can they get those services done? So in this first year, we just want to start off very, very small. It would be in a voucher format. We want to see if they can provide those services. For homemaker, respite, and chore services, very specifically on the homemaker and the respite, there are training requirements. And so we are trying to figure out the best way to address that. We have proposed that we utilize the training offered by our current providers and tag team that family member or friend with them. We might also actually ask for a waiver to not have to provide that same amount of training because of the funding source that we're utilizing. We'll see how that goes. In the second year, we would like to transition away from the paper voucher into our Mainsail system. That system is a completely electronic process that our waiver employees have to use. They go on, it captures GPS, it gives them a list of activities, and would allow all of that to be done through that system. The case manager is still going to be very much tied to the client. They're going to continue to monitor for service utilization and incorporate, you can see the word CAP there. And basically what that is that if we recognize that employee, their family member is not doing what they have agreed to do, we can basically say that you're kind of put on a little probation period. And if you don't start doing this, then we're going to have to terminate the services. And so all of that conversation would happen with the client, their family members, if they're involved, and treating it from a holistic perspective from that side. So again, it's a very small pilot that we're looking at. It's not going to be the end all to be all. We understand that. But when we have individuals who are difficult to deal with clients or live in some outlying, way crazy rural areas, where we just don't have providers who want to travel there or don't have access to get there, we still need to figure out a way to provide those services. And what best way than to look at the caregivers that are currently built into the system. Again, it's not going to work for everybody. We want it to work small, but it is something that we're looking at as a way to really identify and meet a need of individuals that are just kind of deemed right now unserviceable. So we're excited about that one. And then the other one is a slight change. And this has actually been very much a partnership that we've had with with Meals on Wheels of Southwest Ohio and Northern Kentucky. And this is a request that we're making to transition how we deliver a hot meal to an individual in their home. This is actually very, very, very long, and I'm not going to read all of the details in here, but the basic concept is this. The meal provider will take a frozen meal into that individual's home. If they do not have a way to warm that up via a microwave, then our provider is going to actually provide one for them. We've done this in the past when frozen meals first came about. I believe it was Campbell County Fiscal Court who said, we want to do this and we'll cover that cost. So at this point, because the suggestion and the request is coming in from our meal provider, they're fronting that cost. Helps us out, helps the client out, helps them out. So the meal driver will bring the meal in, warm the meal up. And, you know, there's some time there, right? I mean, when you're putting something in the microwave, there's a little bit of opportunity to really be able to have a conversation. And so because we're doing it this way, there's now a little bit of social interaction that gets to happen between the driver and that client, a little more addressing that social isolation that often so many of our individuals who need these home delivered meals, especially the hot ones, just that extra little bit of attention. It's going to be extremely helpful. We also find that individuals often don't want that meal right then and there. And maybe they can, you know, have somebody come over and then rewarm it up for them as well. So again, there's opportunities that we're looking at streamlining how that hot delivered meal process is implemented. It has been implemented this way successfully. It is currently the way that a hot meal is delivered in Ohio. So this is a very natural process. It's not unique or uncommon to what they're doing in their current practices. They're just asking it to come over here. We happen to think that it's a really good idea. So those are the two new things that we're putting in as requests to the state. We're hoping that that we receive approval on those again. We imagine that there's going to be further conversation from the state, but that's okay. So also, you know, this is last little sentence down here. My little sales pitch to you and to the state is, you know, again, as we're looking at ways to meet all the goals that we just spent lots of time talking about, this change is going to result in efficiencies that impact the quality of the meal. Hey, that's goal number 5. We're going to reduce the financial impact because it should result in a lower cost, goal number 3, and we're going to increase client socialization. Hey, that's goal number 1. So one change from taking it in and warming it up is going to impact 3 of the goals that we have.
Great, thanks, Shannon. All right, so the last 2 parts I'll just briefly talk about. So we do have to list all of our for-profit companies that we contract with. So we have that information there. And then the last, I would say, oh goodness, probably about 10 or so pages are assurances. And these are just things as the Area Agency on Aging. I'm not going to read through these. You would be bored to death. That we're required to do as an Area Agency on Aging. They're part of our contractual obligations, and they're things that are in our contract, and they are just what we assure. Back in the day, our area plan was probably about 100 pages long, and the state decided to shorten that, thankfully, by putting these assurances in the area plan. And we are so grateful for that, that's for sure, because it is a lot of work to put this together. And back when we had to do 100 pages, it was a whole lot more, a lot of work. With that, that completes the review of our FY23 through FY25 regional aging area plan. I will, at this time, Shannon and I will entertain any questions that you would have. I know that was a long.
And Shannon, this is Laura Kleiman again. Regarding your pilot, which is really innovative for those direct services as personal and homemaking services, what's that reimbursement look like for those caretakers? How does that work out in this pilot?
You know, that's a great question. And so what we do historically when we're looking at that is we're actually going to go based on what our waiver, kind of what the average is within the waiver program itself, because Medicaid is reimbursing those funds. So we'll look at what that looks like and then propose it. Under the waiver program, in some of those areas, there's actually a range. I don't think that we're necessarily going to go in that general direction. If we look at it from our caregiver perspective, right now for a family and friend who is providing that respite service, it's $12 an hour versus an upwards of $25 for our providers. So there is a significant cost savings.
And then too, it would not necessarily put those folks in real competition with our service providers potentially.
Absolutely, and that's why we built in that they have to be identified as a non-serviceable, client. And we are constantly talking with our providers, and we know probably the number one, the hardest obstacle to overcome for our providers, especially in the rural areas, is just the number of individuals in those rural areas. So, I think maybe if we look at like Pendleton County, maybe we have 20 clients who are getting in-home, if it's even that high.
I'm not sure.
I mean, Grant or Owen County may only have 10 individuals who are utilizing an in-home service. If those 10 are in Owenton, it's easier to be able to say, hey, we got a provider who can provide services there. But as soon as you get that one or two outlier in the farthest reaches of Owen County, those providers don't always want to go all the way out there. So the only issue becomes from providing that service is the fact that we just don't have anybody who's willing to go out there. So it's going to be something that we look at and make sure that they really are in either unserviceable regions or there's just not an aid available. At one point, we had 10 or 12 who had been waiting for over 3 months because there was no aid caregiver. That's crazy, especially if they have access to a family member or a friend who can get in there and provide it. And then there's going to be a process that says, are there opportunities? I know all of our providers are always, and I believe that's part of what they do. They go out and they ask, hey, we just had an A leave. Do you have somebody who you could do it? And would they be interested in working for us just to work for you? So I know those conversations are happening, and ideally we want to begin to link them in there. But, sometimes we just know there's that small population who a family or a friend who's already checking on them could just do so much more. We could just do a little bit more.
Sure, I appreciate that. And then, thank you. It's all so helpful. One additional question with that. Do you have a thought of what percentage of the budget would go to this? You said small pilot. Have you given a thought, like a rough estimate to what that number might look like?
You know what, that's a great question. And no, to answer your question, I have not. And I imagine that that's probably one that we need to talk about internally because I imagine the department's going to ask that same exact question. What we're going to do is take a look at where we're sitting currently. And again, let me just mention, I think out of those 12 individuals that have been waiting for a long time, Stacy, I think almost all of them now actually have a traditional provider because the providers have been working really hard on that. So, I imagine that it could be something as small as 5. And if we prorate, what does that look like? We'll just figure out what the normal services, which for a homemaker service is 2 units. So it's like 4 hours a week, about 2 hours a week, sorry. So we would just, we could take 2 hours a week, multiply that based on a year, based on that rate, and then kind of just, project that out.
Thank you. Appreciate it.
Sure. Thank you for the questions.
Anyone else? All right. Well, thank you all so much for joining the public hearing today. It is 11:26 a.m. and we will now end the public hearing. I hope you all have a wonderful day. Thank you.